Okay, we are going to get started. We still have some more people trickling in, but thank you to everyone who has dialed in today. Today's webinar is 2021 ICD-10-CM PCS code set updates. Thanks for taking some time out of your busy schedules to join us. And before we start, just a couple of housekeeping items. So first, none of the attendees today will be given audio. Everyone will be placed on mute. And we will not have time for a live Q&A today, but we do encourage you to please write your questions into the Q&A box at the bottom of the screen, and we will collect all questions, and we'll be publishing a FAQ document that we will be sharing with everyone in the few days following the event. Our team will be looking into and researching all of the questions that were asked, and we will be publishing the answers to those documents on the webinar page that we'll share the link to later on today. So with that, I know none of you have taken time out of your day to listen to me speak, and that is why I have joined by our presenter today, Lisa Ball. Lisa is a member of our Revenue Integrity Services team at Vitalware. She has more than 20 years of experience in healthcare and more than 14 years specializing in coding and documentation. Her experience includes inpatient and outpatient coding and auditing, education, and documentation, and her coding experience includes work for the Department of Veteran Affairs as lead coder, coding and physician educator, Medicare author, HCC auditor, and DRG validation and insurance auditing. Lisa has her Bachelor of Science degree in Health Information Management and is working toward a Registered Health Information Administrator credential. She's a certified coding specialist and a clinical documentation improvement practitioner. Her experience extends into denials and clinical documentation for rebuttal and appeal review processes. As you can hear, she is more than qualified to give today's presentation. So without further delay, I will hand things over to you, Lisa.
Thanks, Corey. Hello, everyone. Thanks for joining us today for our presentation on the IPPS Final Rule in regards to coding updates for 2021. I'm just going to start off and let you guys know we have a lot of information to go over, so I may talk a little fast because I'm trying to get it all into a 1-hour session because I know all of our time is precious. You do have an opportunity with today's webinar and viewing it live of getting free CEUs through AHIMA and through AAPC. But we're just going to start off with our first slide, making a note that this is just a brief disclaimer. And it just lets you know that at the time of generating this presentation, everything was up to date. If you reference this in the future, just make sure. We always encourage our participants to review the specific guidelines themselves, in addition to our materials, just to ensure that nothing has changed since we created this, this slide deck. So our agenda today includes going over CM and PCS additions, revisions, and deletions within each chapter, and the implications within the DRGs for each section as well, and going over CC and MCC changes. Section 1, we're going to go over just a real quick glimpse of the changes with those total numbers in each area. And then we're going to dive into CM, then PCS, and go over MS-DRGs. And then we're going to wrap things up with just a few slides about Vitalware and what we offer to our clients. So this, we're just going to go over the immediate changes. First, I always like to include the website addresses for our resources. Here I've included an image of where you can go onto the Federal Register website to find that IPPS rule. And why this should be and possibly is a no-brainer to most of where to find this, we can't forget that some people aren't as established in the healthcare arena, and they may need help in finding these resources and getting guidance on where to find these. So I always like to include this in our presentations where we find our resources. And just a note that while the Federal Register generally tries to by the following day of publication or when it's finalized, that's not always possible. And here's an example, on 9/2, on September 2nd, CMS finalized the IPPS Final Rule, but it did not make it out onto the Federal Register website until 9/18 being published. And I mention this because for me, I spent that first week scouring the internet and scratching my head as to where I could find the final rule on the Federal Register's website. I wanted to see it for myself to validate the information that I was putting together for this presentation. I ended up being able to get the final rule on CMS's website, and I'll show that as well. But I just wanted to show that on the Federal Register site, that Friday after the finalization on September 4th, they made this notation of where you could go to get that in the interim. And then I also just wanted to show where in the future, if this ever happens again, you can go on CMS's website, go straight into the IPPS Final or Proposed and Final Rule homepages, and go to the related links at the bottom and find their PDF link to the final rule. So here, this slide just shows stats that we're going to go over with CM for all those totals in new, revised, and deleted codes and additions. We'll go into more detail with those in a second. And here we see the stats for PCS as well. And we'll go over these in a separate section of the webinar. But, just right off the bat, you can see that there was 544 new PCS codes added with no deletions and no revisions. And one of the hottest topics right now at this point with the proposed and final IPPS rule is how they're wanting to shift from the MS-DRGs that we currently know to a market-based rate. And in order for them to do this, starting January 1st, they're going to use the price transparency rule where hospitals will have to start reporting their negotiated charges with the Medicare Advantage payers along with their median charge. We're not going to go over any of this. I'm just making a little note of it. We're going to go into each MS-DRG and show you what the changes are, but they are going to use this price transparency rule over the next 3 years to collect data so that they can implement their hope is to implement and calculate new market-based DRG in 2024. So now let's move into each chapter level within the diagnosis code sections. So there was 595 code changes that were proposed. 490 ended in new codes, and there was 47 with revisions and 58 deleted codes. 128 of these 490 reside in Chapter 19, and 125 reside in Chapter 20. We also ended up with a new Chapter 22 for special purposes that will help with coding of vaping and COVID codes. And 588 codes were added to the POA exemption list due to these new codes and some revisions. Our MCC and CC list had an overhaul as well with 30 new MCCs. There was only one MCC removed, so that's always good news. And then we had 96 new CCs added and 14 deletions. So here we're going to look at the additions, deletions, and revisions. And we want to look at these. I prefer to look at these in a side-by-side analysis. I like going through the changes within the code book to see the changes firsthand and then reviewing them side by side. This helps me to just visually see the difference between the code description, the addition of characters to the code itself. And for your guys' viewing, I also like to show in green any additions and in red any deletions. So we're looking at Chapter 1 in this first slide, and as you can see in Chapter 1, both A840, 84.8 and B60.0 were expanded upon, with MCC and CCs being maintained. And this accounts for some of those additions that we're going to see to the MCC and CC list. Chapter 2 had no deletions or additions. And I see, looks like there's a ton of QAs. I'm just making sure that there's no issues with, okay, with the recording or with you guys hearing me. In chapter 3, we gained 8 more MCCs in this section with codes for D57.03 to D57.433 for those sickle cell anemia expansions, so that they can better account for the specificity of these anemias. The previous section continues onto this slide, and we have 9 additional MCCs for that sickle cell anemia section as well, from D57.438 to the D57.818. Chapter 3 for blood forming disorders really amped up their anemia section, as you can tell with those first 2 slides. And it's continued through to D59.1 for other autoimmune hemolytic anemias. It includes specificity as the type as being warm, cold, or mixed type. And again, supported our CC inclusions for all. Another nice change was the addition of more specific codes for eosinophilic disorders to include lymphocytic variant hypereosinophilic syndrome. And this section will probably continue to grow over time as there's more research going on with finding this disorder in the peripheral blood. And so you're going to see codes added for the body systems of esophagus, stomach, colon, lungs. I personally relate to this section of codes and am really excited to see this area expand. So far, there's not MCC or CC implications at this time, but we might see that later because this tends to create some end-stage organ complications, and they're currently studying that. So this section expanded along with our T-cell therapy PCS codes that we're going to go over in a little bit, and also includes the cytokine release syndrome stages 1 through 5. And this can help in reporting associated dysfunctions from that CAR treatment that can manifest into this syndrome when they're on T-cell therapy. So moving on to chapter 4, we only have 2 code sections with updates for the endocrine, metabolic, and nutritional disorders. Aromatic amino acid metabolism and carbohydrate metabolism disorders were expanded upon as well, and they maintained their CC determinations. And then it also gave us some additional CC opportunities based on that expansion. Here, for this section, I figure coders will be pretty happy to see they've added a 5th digit of 3, which will aid in assigning alcohol abuse and use codes to explain withdrawal and the alcohol use abuse better. This added some CCs as well to the list. And same with opioid abuse. They expanded this section with a 5th character of 3 to note withdrawal as well. And they just continued this on and added code sections for sedatives, hypnotics, anxiolytics, as well as cocaine or other psychoactive substances with the withdrawal. Chapter 6 expands upon codes G11 for early onset cerebral ataxia and G71 for congenital myopathies. G11 differentiates between early onset and Friedreich's ataxia, and then G71 includes more specificity with the Nimelin and X-linked myopathies. So we're going to continue on with chapter 6, diseases of the nervous system, has expansions in code reporting for cerebrospinal fluid leak to include those instances that are spontaneous and not just by puncture, and also other types of cranial or spinal leaks. Cranial cyst was added, and expansions to include intracranial hypotension as well. Chapter 7 for eye disorders for corneal dystrophies has expanded as well. And this was just for them to add laterality of right and left. And we'll also see this later in complications. They expanded there as well for infections and transplant rejections. This slide just shows the additional list of corneal dystrophies that were expanded upon with that laterality, and also code H5581 description was revised just to add that term deficient. There was no changes to chapter 8 or to chapter 9. Chapter 10, again, we see expansions to that eosinophilia that I mentioned earlier. And this section is for the respiratory involvement with J82. And it just notes chronicity and acuity, and to include asthma related eosinophilic. Chapter 11, diseases of the digestive system, here with esophagitis and GERD. We gained 3 MCCs with the 5th character of 1 for bleeding. And hepatic fibrosis was further specified to include early and advanced fibrosis for code assignment. And there was no changes to chapter 12 for diseases of the skin and subcutaneous. Chapter 13, diseases of the musculoskeletal and connective tissue, added a 5th character and created a whole new code with character A for reporting other specified sites. And then they continued this on with additional characters of 9 to show other specified sites and other specified joints. And this slide just continues on with some of those changes within that arthritis section. And we gained some new CCs here as well between the M80-0AXA and M80-8AXP. That gave us 6 new CCs. But it only affected those instances of current initial fracture and those that are a malunion or non-union. And you'll see that with the codes that have a 7th character of A, K, and P. Sorry, I have to take a drink. Here they expand upon the laterality and region of the tibia and fibula with those juvenile osteochondrosis codes in chapter 13 as well. For chapter 14, for N00 section, we've added with the C3 glomerulonephritis with character A addition, and gain 6 new CC opportunities in this section with codes N02A through N07A, and then 2 new MCCs with the N00A and N01A. We also had an expansion upon chronic kidney disease to create codes for stage 3, with them being classified as a stage 3A or a stage 3B. And so this is just helps differentiate about the extent of that stage 3 chronic kidney disease, and it's going to be based on their GFR, their glomerular filtration rate, and the doctor will reference that where they fall in that determination. Chapter 15 got 3 MCs with cerebral infarction codes for neonatal patients. Also in chapter 16, an addition of 4 new codes with P91821 through P91829. And here they just specify laterality for those infarctions. And these were also added to the POA exemption list. Chapter 17, doubling of uterus, was expanded to include referencing if that was a partial or complete doubling. And chapter 18, headache, was expanded to include orthostatic component. And then they took the elevated liver transminase level and the elevated LDH and made them their own separate codes. So for chapter 19 and 20, we mentioned that there was a lot of additions in those sections. So we're not going to spend time on these slides as they're pretty basic and lengthy, but we did list all the codes here for you to have as a reference. And since you'll get this slide deck, you'll have those, you know, to reference. But they have added the 6th character of 3 for contusions with reporting bilateral, and the character 4 for middle. And these codes are also added to the POA exemption list for 2021. And you know, there's a total of 108 codes just in this section. And so what I've listed for that were added to that POA exemption list. So I haven't listed the full 108, but I have listed the codes that were added regardless of the exemption list. And again, these are just, these next 2 slides are just all of those additions. Now, this list of new codes that I have on this code have been added to the POA exemption list as well, from T40411D about the 2nd code down to T40496S, which is on another slide moving forward. And there was 108 new codes just for this section as well. And here they've replaced the 5th character X with character 1, 2, and 9, and so that they could add fentanyl and tramadol and other synthetic narcotics for that poisoning adverse effects and underdosing section. Just as I listed previously, the additions, this slide shows the deletions. You know, this is all of those with the character of X that have been replaced with the 1, 2, or 9. Similar to our previous section for the eye with the corneal dystrophy, where they added the laterality, here's just where they added the laterality to those complications of the transplant with a rejection or infection or failure designation. Chapter 20, again, it's another large section. Here they've just added for pedestrians with an electronic scooter for reporting. And there was 122 new codes added for this section, and 116 of those were added to the POA exemption list. And this just continues on for all those additions with that scooter and the pedestrian. Now we're going to take a look at Chapter 20 for external causes. Code Y77.1, they added contact lens to the description to better specify that ophthalmic device. And Y92002, they updated and removed the verbiage of single family private house as a place description for bathroom. 3 new codes have been added to Chapter 21 for with 3 new Z codes, and have also been included in the POA exemption list. And as you can see, there we have a new Chapter 22 for special purposes that helps with reporting those vaping related issues in COVID-19. And the U07.1 is an MCC as well. Now we're going to take a look at guideline changes for CM. There really wasn't a ton of changes to the guidelines, and some you'll already be aware of through COVID and vaping related areas from back in April and August. In general, guidelines, they make a note that patient self-reporting documentation is usable when it is signed off by a clinician or provider. Chapter 1 just adds the coronavirus section for certain infectious diseases. It updated, but that's been added. Chapter 4 notes for diabetes with long-term drug use. They specify that for both oral and injectable medications, you can report both. Z7984 and Z79899. And then they just make a notation of this as well in the other subsection for secondary diabetes. Chapter 5 notes that psychoactive substance use should only be reported when the provider documents support the use and justifies that, and clarifies that also the substance use should also include sexual dysfunction and sleep disorders within the mental health section. Chapter 9 for circulatory system disease just clarifies that when both acute renal and chronic renal or kidney disease is present, to code also the acute renal failure. I'm not sure why this had to be clarified, but it was, and they note the sequencing will depend on the circumstances of that encounter. So there must have been a reason for them to feel like that had to be clarified. Chapter 10 updates the section for vaping with the U070 to be listed as principal, with other respiratory codes reported secondary. No need to report cough or other symptoms if a definitive diagnosis is available, but GI-related symptoms such as diarrhea or abdominal pain would be appropriate to report additionally. Chapter 15, they clarify COVID-related illness coding with pregnancy and childbirth, that the 098.5 would be the principal, followed by the U07.1 and other manifestation codes, as those Chapter 15 codes always take priority. Chapter 16 with newborn COVID guideline notes that when a newborn tests positive for COVID, to use U07.1 only when there's no linkage made for that contraction of COVID being transmitted in utero. And also to code P35.8 for other congenital viral diseases with that U07.1, and to remember to still report your Z38 as principal. Chapter 21 for Z code selection. Here they just clarify the usage of observation codes when a patient is admitted for observation of one condition, and while they're also being observed for suspected COVID that's ruled out. The observation code, although it's primarily used for principal or first listed, in these case scenarios would be an additional code. And with the new Chapter 22 for special purposes, they added a vaping and COVID section in Section 1 of the guidelines. So now we'll move on to PCS changes. Similar to the previous section with CM, we'll go over the additions for PCS and then look at any guideline updates as well. As you can see here, 44 new PCS codes. However, there is listed on CMS's website 556 new codes. And the reason that there's a difference between that number, it's due to 12 of these codes have already been released back in August due to COVID. And that was noted in version 37.2 of the grouper. Here you can see a quick breakdown of the additions by section for total variances between 2020 and 2021. I like being able to see that. And here we're going to go over each change individual, this chart I created so that we could see within each individual PCS section and body system the number of changes in just one view. And so this is the entire med surgical section, and you can see that a great deal of the changes happened in the heart and great vessels, as well as the upper and lower arteries and veins, with new tables for fragmentation added. And you can also see under the spinal fusion for upper and lower joints that they've added fusion, a lot of fusion, new internal fixation device codes as well. And this is a view of the other sections between OB to new technology. And a significant number of changes happened in the imaging, hepatobiliary system, and pancreas, where they added new tables for other imaging, as well as in the new technology with introduction and transfusions, adding for those T cell therapies. So we're not going to go over each one individually, all these changes, it's just too vast. We're just going to go over the biggest section changes with new tables. And so you can see on this slide in that med surgical section, as I just mentioned, they added fragmentation as an operation to several body systems, that heart and greater vessels, upper and lower arteries and veins. They also added transplantation as a new table to the male reproductive system. And just that fragmentation and transplantation, there was 122 new code options available. 28 new code options are available due to a new subtype in section B for imaging that's been created. And so this is other imaging, and it was added to help with not elsewhere classified PCS code selections. And an example of this could be the ICG used with intraoperative imaging of the biliary system during a cholecystectomy. So it just, without them having to expand that section so much, it just allows for additional reporting. And also, as mentioned earlier, in the new technology section with supplementation and transfusion for bone and anatomic regions, this included helping to support reporting those T cell therapies. The radiation section, we have 64 new opportunities for code selection with brachytherapy. And you know, the cesium-131 isotope, it's pretty common, but there wasn't availability for a code option before, but now we have it. In conjunction with that brachytherapy addition, there was a device value radioactive element added to the root operations insertion tables for several body systems. And so that added another 157 codes. And that also helps support coding conventions where they need to assign a separate code for brachytherapy procedures when a radioactive source is left in the body, like radioactive seeds. With new technology, many of the proposals to add codes were created to support CMS's new technology add-on payments. Many of these proposals were for techniques or equipment not typically found for a hospital stay, but we are going to mention them. And we haven't listed all of them here, but this list does show a few of the additions in the tables to XW0 and XW2, and that will expand over the next few years, I'm sure, quite aggressively. CMS finalized a different option from what was originally proposed at the coordination and maintenance meeting for these T-cell therapies. And so on September 8th, to help with some of the confusion, CMS included some guidance and comments on this process. And I've listed that link here so that you can go out and reference that to help you in some of those coding scenarios with the examples that they've released. So for PCS, there was no deletions or revisions. Yay. It was mostly just additions and new tables. We do have some updates for the PCS guidelines. Our first one was with section B3 for root operations with clarification of excision and resection followed by a replacement. And so B3.18 was added to note some examples of this. And they actually moved an example from another section to hear about mastectomies. And we'll go through that as well. One of the examples that they used for this guideline and reporting both the excision resection and the replacement is with maxillectomy and obturator reconstruction. They also use excisional debridement of tendon with skin graft and an esophagectomy followed by reconstruction. However, they did continue with 2 more examples with this excision resection followed by replacement. But in this one, they use a joint resection as when you would not code both the replacement with the resection. We know as coders that, you know, you have a hip resection with replacement, you're just going to code that with the replacement. B5 section, what they did here was they needed to expand this section, so they added an A to B5.2, and so that they were able to create B5.2b. And here they were just for percutaneous endoscopic approach with extension of incision for assistance in removal of all or a portion of a body part, or to anastomose the tubular body part to complete that procedure. When it is performed percutaneous endoscopic, it's still going to go to that value percutaneous endoscopic. Just because they opened it up a little bit further is not going to make that an open procedure. And here they just give it further examples of that scenario. Our last update to the PCS guideline includes section B3 for root operation. This section is not an addition per se, but a revision with removal of the exception notation I mentioned earlier, that mastectomy. They moved that under that other B3.18 guideline. And then they just further clarified with fusions that it's bone graft or bone graft substitute, and took out a loan or other material. Now we're going to look specifically at the MS-DRG changes. Starting with pre-MDC, 8 codes were reassigned from pre-MDC category as a surgical weight to non-OR. There was a bit of inconsistency here, so with these codes removed, the previous 14, 16, and 17 pre-MDC or MS-DRGs are now medical, or the pre-MDC are now medical MS-DRGs. Oh, I skipped. So a critical part of the IPPS Final Rule includes a provision to provide hospitals with this predictive payment to help with this chimeric antigen receptor CAR T-cell therapies. And so since they're no longer considered for the new technology add-on payment, the XW033C3 and the XW043C3, they are going to increase the payment by 0.18% and the estimated volume by 25%. From the proposed final rule, they're making that final. And that will increase per case the payment of almost $240,000. And it's going to increase those percentages of payments for oncology services. So even though it's no longer an add-on payment, they are expecting an increase. And CMS also made note that they're going to distinguish between clinical trials and non-clinical trials, so that they understand that the cost of the drug is not factored into a clinical trial, and that way it doesn't affect their reimbursement determinations and calculations for rates later. 6 ICD-10-PCS procedure codes describing dilation of the carotid artery with drug-eluting intraluminal devices using an open approach. They were assigned to MS-DRGs 37 through 39, but they will now be reported to MS-DRGs 34 through 36. And I have those listed here for you to reference as well. So this slide and the next 2 slides show 36 procedure codes that describe dilation of the carotid artery with intraluminal device that have an open approach. And so to help streamline the reporting of these codes, they were added to MDC 1 in addition to MDC5. And their hope by doing this was to avoid these getting rolled up into 981 through 983 MS-DRGs, where these weren't mapped properly prior. And by doing that, these should go to MDC 252, 253, 254, and as well as 34 through 36. And this just continues on with those 36. MDC3 for diseases of the ENT. As a result of the data analysis that they performed for the MS-DRGs 129 through 132 for procedures describing replacement of TMJ with prosthesis, it was recommended to evaluate these. And so basically the data analysis shows that there was a wide variation in the volume, length of stay, and average cost of these cases. So what they did was they took the less resource-driven procedures and placed them in MS-DRGs 140 through 145. MDC5, 3 procedure codes listed here for occlusion of atrial appendage open approach were reassigned from 250 and 251 to 273 and 274 MS-DRGs. Additionally, 24 code combinations were added to MS-DRGs 222, 223, 225, 226, and 227 for, of the cardiac defibrillator implant when it's not performed with a cardiac cath. And then 12 code pairs have been deleted for insertion of a contraction device in the atrium and ventricle. So here, and the next slide, we just have those 24 combinations listed. And on this slide, we just have the 12 codes that were deleted from that insertion of contraction device. New MS-DRG 521 and 522 were added for hip replacements and have been created. There is several diagnosis and procedure codes that affect this new DRG. Just too vast to list, but you can go on CMS's website and review tables 6P1D and 6P1E for those. MDC11, diseases and disorders of the kidney and urinary tract. So for this one, there was an issue with reporting I-13-2 for hypertensive heart and end-stage renal disease with a kidney transplant procedure. It was grouping to MS-DRG 981. And so in regards to the transplant alone, MS-DRG 652 was one of the only transplant DRGs that was not a pre-MDC. So the best option they found was to move these transplants under the pre-MDC classification. In regards to the simultaneous kidney and pancreas transplant with hemodialysis, this was very resource consuming, and a pre-MDC MS-DRG was needed to separate out this type of situation, even though it's not too common. So this pre-MDC will have a two-way severity level split. And so there was 2 MS-DRGs created, 650 and 651. And so the manner in which these cases get assigned, it's very difficult to explain for grouper logic. But they do have a list within the Federal Register and a diagram to reference for making that determination. Initially, it was requested that 29 diagnosis codes be added to MS-DRG 673 through 675 when performed with a totally implantable vascular device and tunneled vascular access device. And these ranged from kidney transplant complications to diabetes with kidney disorders and hypertensive heart and kidney diseases to complications due to infections. And this request was due to multiple patients with a kidney transplant also suffering from a dialysis catheter complication. And since that complication code needs to be principal, that was creating issues with the appropriate DRG categorization. And so they ultimately determined after review that they would recategorize various diagnosis codes differently, with the first change applicable to just these 4 diagnoses, and to see how that pans out. Additionally, the following codes for diabetes and diabetic chronic kidney disease or drug-induced diabetes with chronic kidney disease were added to MS-DRG 673 through 675, as they could imply a need for an implantable tunneled vascular device. ICD-10 diagnosis codes I-12-9 through the list here to N-18-9 do not describe renal failure and do not describe indications that would generally require the insertion of a totally implantable vascular access device or tunneled vascular access device for the purpose of hemodialysis. And dialysis is not often initiated for chronic kidney diseases until it reaches a stage 5 or end stage. So CMS determined these 7 codes do not describe indications requiring the insertion of these devices, and so they've been removed from that MS-DRG logic for 673 through 675. And here they're just noting that they will, that insertion of intraluminal IVC devices to maintain their OR procedure list determination, and 1 was changed to a non-OR. All right, so annually the Maintenance Committee reviews MS-DRGs 981 through 983 and 987 to 989. And so I'm going to try and speed up a little bit here. We only have a few more minutes. So here they've just noted that procedure 0J9B077 for drainage of the perineum, open approach, was added to MDC-06 for MS-DRGs 356 through 358, but only when it's used in conjunction with an MDC-6 principal diagnosis, such as a horseshoe abscess. Here we note that there have been 3 procedure codes added to MDC-8 for MS-DRGs 515 to 517. And basically, they found that there was an issue with chest deformities from MDC-8, that diagnosis code, not showing as relatable with a supplementation of the chest wall. These following 2 procedure codes have been added to MDC-7, MS-DRGs 423 through 425. Other hepatobiliary pancreas procedures, with restriction and occlusion when used with a hepatic malignancy code. Here we have 3 procedure codes that have been added to MDC-4 for MS-DRGs 166 through 168, occlusion of upper arteries when used in conjunction with hemoptysis. And just note that principal diagnosis of hemoptysis is not normal. Generally, there's a more descriptive, definitive diagnosis. And these procedures have been added to MDC-3, new MS-DRGs 143 through 145, occlusion codes to help get things out of that 981 to 983. And these procedures, revision of synthetic substitute in the peritoneal cavity, were added to MDC-1 for ventricular shunt procedures. I'd go in more detail, but running out of time. And here we have 9 procedure codes that have been added to multiple MS-DRGs in an effort to avoid placement in 981, 983 as well for those inserted total implantable vascular access devices. We went over a few of the indications. And here we have 161 diagnosis codes were reassigned that identify multiple significant trauma combined with internal fixation of joint procedures. And these were reported to 981 through 983, and now they're going to report to MS-DRG 957 through 959. So this is our last review for MS-DRG changes, and so far in the last several slides we've gone over scenarios where reassignment of procedures and diagnosis codes removed something from a 981 and 987 through 989. But here we have a scenario in which one situation just moves basically from the 981 to 983 section to 987, 989. And this is an excision of the mediastinum, open approach, goes to that 983, 989 MS-DRG now. So now we just have a few more slides to go over OR and non-OR changes. We didn't list them all, and there's no inclusive list anymore for this. So we've just listed the main ones that were in the final rule. So here we have 3 endoscopic revisions of feeding devices that have gone from OR to non-OR. Here we have percutaneous endoscopic biopsies of the mediastinum that have gone from non-OR to OR. And here we have drainage of the peritoneum, peritoneal cavity, and gallbladder that have also been moved from non-OR to OR. And the following excisions of the duodenum, jejunum, and ileum with open approach are now considered extensive OR procedures. And following along with the drainage procedures for peritoneum, peritoneal, and gallbladder with open approach, these are now non-extensive procedures, OR procedures. So we'll finish up the MS-DRG section with a brief look at the changes to the new technology add-on payments available. Here you can see a breakdown of what treatments are being removed and continued and the effect on the payment. And we have those treatments that are now new to the add-on payments for 2021. So that wraps up our webinar. Sorry I rushed there at the end. But we did want to just take a minute to let you know more about us. We really work hard for our clients and hope that it shows in the webinar. We like to take great effort in our content and keeping up to date on policies to help you succeed. Vitalware offers a lot of products and services to help make the business of healthcare easier. We have our Vital Knowledge tool, which provides your compliance, revenue, and coding teams with access to current medical coding information. Our tool has an easy-to-search interface, and our team of experts work diligently to ensure your content is up-to-date and accurate. We also have Vital CDM. We consider this the new ChargeMaster standard in management because there isn't any data limits, and you can manage your CDM, EAP, pharmacy, supplies, and other ancillary files from the same solution. And we have both a post-bill and pre-bill offering with Vital Analysis, our post-bill product, and Vital Integrity, our pre-bill product. And lastly, our Hospital Price Index, or HPI tool, which is at the moment, price transparency is making more headlines than the IPPS rule itself, but we have our own HPI product to help you with this regulation. So if you're interested in a demo or more information, please feel free to reach out to us at vitalware.com. Thanks again so much for your time today. We really enjoy working with each of you and look forward to working with you in the future. So Tori, I'm gonna throw it back over to you.
Great, thank you so much, Lisa, and nice job getting through all that within the time allotted. Again, to the audience, we will not be doing a live Q&A today just because we had such a dense topic to get through, but we will be sending out a copy of the presenter's deck following the presentation today. And additionally, we will be looking into some of the questions that had been provided in the Q&A panel. Please feel free to continue putting your questions in there. we will take them back to our team and research answers, and we will be publishing a frequently asked question document that will be available on the same page that we'll be sharing with you all later this afternoon, where we'll house the recording as well as the presenter's deck. So with that said, thank you all for joining again today. We hope you enjoyed the session and found it informative. And as mentioned earlier, we'll be getting all of that information up on our website between this afternoon and over the next few days, depending on some of the questions that come in. If you would like any more information on anything you saw today, please feel free to reach out to your Vitalware account manager or come to our website where you can chat with us, fill out a form to get a demo on any of our services or solutions, or you can find our phone number there as well if that's the method of communication you prefer. You could also feel free to follow us on Facebook or LinkedIn and stay informed on all of our latest and greatest content and our webinar schedule. So with that, thank you again and have a great day, everyone.